Good morning. Thank you all for coming and being participants in this session. I am extremely honored to be part of the 18th Congress and to be invited to this, to speak to this group about vascular ultrasound. I'm giving a number of talks. The first one is about interpretation of carotid scans. Just a little bit about me. I am an academic vascular surgeon. I am not primarily a sonographer or a radiologist. I work at a school of medicine and at a number of hospitals, a large university hospital and also a smaller inner city hospital. I direct a vascular laboratory where we do vascular ultrasound, and I'm very much involved in credentialing and accreditation of vascular ultrasound in the United States. I have no industry relationships to declare. This is a brief overview of what it is that I'd like to talk about today. I'd like to review the basic components and of protocols related to ultrasound of the carotids, talk about some fine points related to Doppler, interpretation of stenosis, and then some confusing situations. So I think we all know that the cerebrovascular duplex scan consists of a number of different components, and we look at different arteries and use different assessments. We have a direct evaluation of the carotid arteries in the neck, the common, the internal and external carotid arteries, and, wrong button. Oops. And the direct examination combines both imaging and physiological data. We have a limited assessment of the vertebral arteries. They can only be seen in a few places, and I'll say a few words about the vertebrals. And then there's indirect assessment of arteries outside of the field of view of ultrasound. These would be arteries in the head or in the chest. There are three components that we look at when we do cerebrovascular duplex scanning: a grayscale imaging, color Doppler, and then pulse Doppler with spectral analysis. I'd like to point out things that I'm sure everybody knows, but both the grayscale and color Doppler are very qualitative features that are helpful, but the actual diagnosis of significant carotid stenosis is made with the pulsed Doppler. So there's a lot of different guidelines available for how to perform ultrasound of the carotid arteries, and this is just a sampling of various organizations in the United States that have published guidelines on carotid duplex, and there are a host of other guidelines around the world, most of which are similar and have common elements. And so I'm not going to focus on any particular one, but talk about things that I think are important for people to understand when we do assessment of the carotids. So first, I'd like to talk a little bit about grayscale. And I mentioned before, it's a qualitative assessment. It is really not suitable for trying to assess a degree of stenosis. And people have spent about 30 years trying to characterize plaque and determine whether there's any increased meaning to hypoechoic plaques versus very echoic plaques, and is one lipid rich and more likely to produce a symptom than another. And the fact is that there's no way to predict based on that. The stenosis issues and concerns, I think, are pretty familiar to everyone. And when we look at a grayscale image, we're always looking at a two-dimensional view of a three-dimensional structure. And depending on which direction your ultrasound beam is passing through the blood vessel, you can get different ideas of the degree of stenosis. So grayscale for stenosis assessment is really unsatisfactory. A few words about color Doppler, extremely helpful in the carotid evaluation, but helpful, not diagnostic. And so here's a nice picture of a carotid bifurcation here, internal carotid, external carotid. There's some plaque here, and look at all this aliasing. Isn't that bad? Well, we have no idea what degree of stenosis that represents. So most of the focus then goes on the spectral analysis of the Doppler signal. And in order to evaluate this, you have to have a basic knowledge of the various normal characteristics. And I've listed them here. Again, people who do vascular ultrasound are familiar with this. The internal carotid artery supplies the brain. It's a low resistance bed. And therefore, there's a lot of diastolic forward flow during the cardiac cycle. The external carotid artery is more like a peripheral artery, supplying the muscles of the face. And the common carotid artery, since it feeds both of those beds, has a sort of a blend spectrum. All of the arteries should have a similar symmetric kind of acceleration phase, and we'll talk a little bit more about that later. And if there are asymmetric contours, it's something that needs to be explored further in the interpretation of the findings. So this is a little slide that shows you normal findings in a number of different arteries that you'd be looking at in the carotid exam. Internal carotid artery, I'll start over here in the left lower. This is a low resistance signal, very characteristic. Vertebral artery has the same low resistance characteristics, supplying perfusion to the brain. The external carotid, high resistance, little reversal of flow here, but very little diastolic forward flow. And again, the common carotid artery is kind of a blend of the internal and external signals. So when we interpret duplex ultrasound of the carotid, it's very important to use criteria, to select criteria that are validated and that are appropriate for the population that you're dealing with. So different populations, different equipment, there's different physicians and different sonographers. So there is a burden to try to pick criteria either from the literature or that are developed locally that apply to the actual patients that you're examining. In addition, depending on the size of your laboratory, some have just one or two sonographers, others have many, but whatever criteria you use need to be uniformly applied to all studies by all interpreting physicians. Otherwise, there can be confusion on repeat studies. And of course, you need to have quality assurance, and any time that there's a deviation from the criteria, it's something that requires explanation. So when we assess a carotid duplex scan, a series of images or loops, we look at the quality of the images, the completeness of the exam, examine the spectra like we described, and then we really want to look for consistency between the grayscale, the color Doppler, and the spectral analysis. So basic components, when we look at stenosis, are listed here. You want to scan proximal to the lesion. Lesion might be identified by the presence of plaque or turbulence on color Doppler, but then you want to use the pulse Doppler to examine proximal to the lesion, within the lesion, and immediately beyond it, and then as far distal as you can in your examination. Within the lesion, you're going to see some characteristic findings that we'll talk about in a little bit more detail. The high point of the stenosis is the stenotic jet, where we have focally elevated velocities within the stenosis itself. And this is an increase compared to the pre-stenotic proximal segment. That's why examination of that area is important. Distal to the stenosis, we'll see turbulence. So within the stenosis, we often have laminar flow with high velocities and then lots of turbulence immediately distal. The velocity increase is what we use to grade the stenosis. So here's an example of a proximal internal carotid artery stenosis. The carotid bifurcation is here. Here's the internal carotid artery. You see a low echogenicity plaque here and an increased peak velocity, 216 centimeters per second, right at the narrow spot there. This is the jet within the stenosis itself. Beyond the stenosis, we often will see post-stenotic turbulence, and that's characterized by spectral broadening, loss of the spectral definition within both edges of the spectrum, and then bidirectional flow indicating significant degrees of turbulence. In individuals with very severe stenoses of the carotid artery, we may also see tardus parvus flow patterns, tardus a prolonged acceleration phase, parvus low velocity, and I think everyone's familiar with this kind of characteristic, delayed upstroke and a low peak velocity. We don't see that very commonly in the carotids, but with very critical lesions, you may be able to see this finding, and it clearly confirms a very serious stenosis. I mentioned before the importance of symmetry, and it is important to put what you see in both carotid systems, both vertebral systems together as a way to synthesize what you're seeing beyond the area of a carotid that can be examined directly. In general, velocity spectra in the various arteries should have similar morphology. In other words, a similar rapid upstroke, similar resistance characteristics. And again, this varies from the carotid, from the internal and external carotid, but the carotid, internal carotid and vertebral should have similar characteristics. And the peak velocities are generally within the same ballpark side to side. There can be exceptions. The vertebral artery is one. There's often hypoplasia or asymmetry of the vertebral arteries in as many as 20 or more % of people. So when you see symmetric aberrations in the shape, pulsatility, or acceleration, that generally suggests a central problem, a hemodynamic issue related to heart disease perhaps, or maybe the patient's physiological condition. If it's asymmetric, it often points to an artery that's beyond the area of insination that has a problem with stenosis or other types of disease. Maybe intrathoracic, or it may be intracranial. So this is an example of a number of different symmetric alterations, and I've just showing the common carotid arteries here, but you have to take my word for it that these same waveforms or characteristics of the spectra were seen in all the other cerebral arteries, and each of these is as an illustration of different types of disease, and I think they're certainly of interest. The panel over here shows the characteristics we see in patients with severe aortic regurgitation, where you don't have forward flow during diastole because it's all being returned to the ventricle. Aortic stenosis, a delayed acceleration phase diffusely. This is a patient with a left ventricular assist device and very little pulsatility. And here's an individual with characteristic flow patterns you see in an intra-aortic balloon pump. So these kind of findings will be seen in multiple vessels and indicate a systemic issue. So an asymmetric alteration is something like this. This is an internal carotid artery with a markedly high resistance characteristic, very clipped forward flow and virtually no diastolic flow. And this is the thing that you might see in a internal carotid artery in the mid-neck when there's a distal, usually intracranial, internal carotid artery stenosis that's quite severe. You may see asymmetric alterations, and this is a comparison of the right and left common carotid arteries in a patient. And on the right side, we see peak systolic velocity of 55 with a very delayed acceleration phase in a normal appearing artery. On the left side, the peak systolic velocity 190, rapid acceleration phase. And this actually is a patient who had a brachiocephalic artery stenosis, proximal to the right common carotid artery. So looking at the asymmetry side to side is something that makes that diagnosis. There was no plaque in the cervical carotid bifurcation. So looking for symmetry identifies this disease and makes the diagnosis. When we talk about Doppler, I think it's really important to consider the impact of the frequency shift and the conversion of frequency shift to velocity. And remember that the velocity determination in a duplex scanner is done, it's a calculation, and it's a complex calculation that fortunately is done for us by the machine, but it's based on a number of assumptions. It assumes that the flow is laminar, or at least relatively laminar, and that the flow is roughly parallel to the artery wall. And unfortunately, neither one of these assumptions is always present, and we have to always be vigilant to look for deviations from this when we try to interpret Doppler findings. This is a nice cartoon showing the Doppler effect, and of course everybody knows the Doppler equation. We could I take this slide down, everybody could write it down, I know. But of course we solve the Doppler equation for velocity. And so when you do that, that puts this cosine term here in the denominator, and that causes some significant problems when we have angle deviations. And again, when you try to line up the cursor with the wall of the artery, this is just an illustration of how you can be off in one dimension. But remember, we're looking at a three-dimensional structure. So frequently, we're off in that z-axis that you can't actually see with your two-dimensional duplex image. This is further complicated by the fact that the flow in the carotid bifurcation is often not laminar. And this is because of the structure and the shape of the carotid bifurcation, which causes all kinds of crazy flow patterns, flow separation, helical flow patterns where the artery flow is sort of circular up and down. And we can see this on Doppler. This is a normal appearing carotid bulb region. And this will just turn the color on, and you can see how the flow pattern is odd in this particular area and how that could impact your ability to accurately place a Doppler sample with parallel to the wall and parallel to flow. The impact of angle of insination is also amplified in individuals who have relatively abnormal flow patterns. So this is a very interesting little diagram from a not recent, but useful, looking at the same carotid artery at different angles, 40 degrees, 50 degrees, 60 degrees, and 70 degrees, and looking at the velocity calculations done by the machine. And you can see that there is a general increase as the velocity goes up, as the angle goes up in the measured velocity or calculated velocity by the machine. But that difference is much greater when you look at mildly or moderately elevated velocities. So this exaggerates abnormalities and may lead to misdiagnosis. So when we do velocity measurements, we often make a big deal about this, the angle of inclination, and for Doppler, 60 degrees has become sort of a magic talisman. I don't know what to call it. It is what we do. There's nothing particularly magical about the 60-degree angle, although the cosine of 60 degrees is 0.5, makes calculations a little bit easier. The important thing about it is that it standardizes the error that's involved in the calculations that we were just talking about, so that from exam to examination, we can be fairly confident if we use the same Doppler angle and we make sure that the cursor is appropriately aligned, that we're going to have measurements that will be comparable from day to day and sonographer to sonographer. So then we get to diagnostic criteria. So this is the thresholds and various other numbers that we use to try to assign a degree of stenosis to the findings that we see on the velocity spectrum. And there's been a lot of different criterion that have come up. They have been validated against other imaging modalities, most commonly validated against digital subtraction arteriography. There are more recent studies comparing duplex findings to CT and MR, but I think most still base it on the findings of digital subtraction angio. And different criteria or criterions are selected: peak velocity or maybe frequency, diastolic velocity, various ratios, and what kind of thresholds you select determine the sensitivity and specificity of the examination. And just like there are many different protocols for carotid ultrasound, there are many different diagnostic criteria. And this is from a paper that looked at the Society of Radiologists in Ultrasound proposed criteria that I'll show you in a minute. But this is one of the tables from that paper showing the various validated criteria that were around in 2003. There are more now. So there's a lot of different numbers that you can pick from the literature to use as your criteria. This is the table from the Grant paper, which looks at the SRU, or the Society of Radiologists in Ultrasound, consensus criteria. And these were generated by a consensus conference, not a research study. And you can see that there's grades of stenosis: normal, less than 50, moderate stenosis, greater than 70, and occlusion, and various velocity cutoffs. They have what they call primary parameters and then additional parameters. So there's both primary criteria and secondary criteria. The secondary criteria include end diastolic velocity and various velocity ratios. You run into a problem with the SRU criteria if you use them, because sometimes the different criteria are in conflict. So in this particular case, this is the internal carotid artery of this patient. Here's the common carotid artery. And if you calculate the various things here, the internal carotid peak systolic velocity is 271, which would put it in the greater than 70% category. The end diastolic velocity is less than 100, so that would put it less than 70%, and so on. So when you have multiple criteria, the question is which one do you apply in which situation, and that leads to different interpretations by different physicians on different days, which is not good for decision making for the patient. So my view, and those of many, is that you should really have a single criterion or a single metric that you use for each level of stenosis. And I think the velocity ratios are most useful when there might be confusion. This can happen in systemic hyperdynamic states. The patient in the trauma bay, the young person who's been shot or has some kind of injury, agitation, sepsis, things like that. And also in the setting of a contralateral carotid occlusion, which affects flow in the remaining patent carotid. So this is a model of that kind of a criterion set. This actually comes from a friend of mine, Larry Needleman at Jefferson University in Philadelphia. And again, the idea here is that there is a single velocity cutoff for each level of stenosis. And initially peak systolic velocity and then end diastolic velocity. And we use a similar thing at Maryland. This is basically the criterion we use. The differences here, we use a little bit lower peak velocity to identify some stenosis. So we want to have a sensitive test to identify disease. And then we use a little bit more stringent criterion to identify the more serious stenosis. And that's really what you need to do when you develop your own criterion in your laboratory. Know your patients, know your equipment, know your techs, know yourself, and then select criteria that fit the patient population. So I tend to use a stringent criteria to increase the specificity of the examination, reduce false positives, because I'm a vascular surgeon. I will do carotid surgery based on the findings of carotid duplex. So I have to be very confident that there's at least a 70% stenosis whenever I'm going to operate on somebody. So I want a very rigid criteria to identify patients who might be at risk and maybe would benefit from primary or secondary prevention of cardiovascular disease. You want a more loose criterion. Important thing to remember, the peak systolic velocity measurements can be misleading in high degrees of stenosis, and this little illustration shows that. As the degree of stenosis increases here, the velocity goes up and up and up and up until you get about 95% stenosis, and then the velocity will markedly drop off. So these critical stenoses, you could have high or low velocities, and that can be confusing. So you have to be aware of that potential problem. When we make the diagnosis of internal carotid occlusion, I think it's important to use all the various tools that are available on your machine. I think the color and the power are particularly useful in this situation because you can identify small areas of flow that might be missed on other methodologies. With pulse Doppler, you'll see no signal. Usually there's a pre-occlusive thump in the proximal internal carotid artery that you could mistake for patency of the artery. And you'll notice in the ipsilateral common carotid artery, there's usually be a loss of diastolic forward flow. I think that's the most important thing. The contralateral internal carotid artery may have compensatory flow and increased peak velocities to maintain global perfusion of the brain. So here's a carotid occlusion. This is the internal carotid artery here. There's an echogenic plaque here, and no Doppler flow detected distal. And so here's the common carotid artery in the same patient. Again, really absent diastolic forward flow, which is a finding we would expect to see. And this is, again, where you want all of the images from the carotid artery, ipsilateral and contralateral, to support the diagnosis that you're making in these cases. So this is an example of a thrombotic occlusion and illustrates using the various components of the duplex scan to confirm what you see. So in grayscale, you see low echogenicity material in the internal carotid artery. Looks like thrombus. The color Doppler helps you. The power Doppler confirms that, and the pulse Doppler shows no flow. So use all the tools available. I mentioned before that when you see an abnormal velocity spectrum or contour, you have to put this together to make a story that makes sense. So here's a spectrum from the distal internal carotid artery. Peak systolic velocity is only 20 centimeters per second. However, the lumen seems to be relatively large on color. There's no plaque in here, not a lot of turbulence, and the low peak systolic velocity indicates low flow. And so the diagnosis in this case happened to be a distal internal carotid artery stenosis. This is another variant that looks a little bit more like a distal occlusion. And again, you can be confused here. Here's that high resistance signal we see, very little diastolic forward flow, very clipped. Peak velocity is not that low, it's 58. In here, the lumen was narrowed, and this is a finding you may see in a long segment stenosis. So putting together the diameter that you estimate with the color Doppler and with grayscale with the characteristics that you see on the flow is how you determine the proper diagnosis in these cases. In other settings where the peak systolic velocity may be misleading, if the artery is tortuous, that can be an issue. We see as the blood goes around a corner here, the velocities are higher outside the curve. We talked earlier about hyperdynamic states. And then, of course, you can always have technical issues with bad angles or bad gain settings. A few other things just to touch on quickly as we wind up. Arrhythmia can be a problem. Which one of these peaks do you select as the representative of the flow? Generally, you don't want the compensatory flow peak here. You'd like to pick sort of an average one, but that's a lot of judgment can go into that in some patients with arrhythmia. The calcified plaque's always a problem. It basically shadows out the area. This is where knowledge of what to expect in the artery a little distal to a stenosis or a little bit further distal to a stenosis can be quite helpful. So we can't get any sonographic information from the area, this area here, but just distal to it, we see relatively nice spectrum, but elevated velocities. So probably there's a significant stenosis in here that we cannot identify. Little pulsed power Doppler shows us some flow here, probably also consistent with a greater than 50% narrowing. I mentioned before about plaque characterization, and again, I think the attempts to use plaque characterization as a predictor for risk of stroke or embolization from a carotid lesion has really been a complete failure, even with ultrasound contrast. However, it is useful to know the plaque is there, and I think some judgment of how much plaque there is useful to help you with putting the findings you see on flow into perspective. So here's just some pictures of funny-looking plaque, and again, I don't think there's much to say about this. The thrombus is generally easy to characterize. This is a mixed heterogeneous plaque. I don't know what's going on in here. That's probably a relatively lipid-rich area, but we cannot make any predictions on it. So a couple of final comments about the internal carotid artery. Remember that the criteria that we talked about before were all developed to identify stenosis of the internal carotid artery. And therefore, they were developed to assess relatively short lesions, because atherosclerosis in most cases is a relatively short lesion in the carotid arteries. And they're in a particular location. These criteria really cannot be applied to the other carotid branches, or even the vertebral artery. So if we look at the common carotid artery, there's really no accepted criteria to detect stenosis in that artery. Generally, you should think there might be a stenosis if you see an elevated velocity, 170, 200, something like that. And you evaluate these lesions if you see them the same way you would evaluate a peripheral arterial lesion, looking for an increase in the peak systolic ratio. 2 would indicate about a 50% stenosis. Can't always get proximal to the lesion in the common carotid artery, but the contralateral carotid can help with that. External carotid, again, no accepted criteria. It's useful to describe whether there's plaque there. And you know, why even bother with it? It doesn't have any impact on stroke risk, but it may help your referring doctor because it may explain a cervical bruit. So a patient may have normal findings in the internal carotid, but the bruit is coming from a stenosis in the external. So here's a normal external flow pattern. I showed you this slide before. And here's one I think you can probably say has a stenosis. Peak velocity is over 500. Big plaque here in the proximal, and I don't think you're going out on a limb saying there's a narrowing there. Vertebral artery, just a couple of words about the vertebral artery. We can only see the vertebral artery within the transverse processes between C2 and C6. This is the V2 segment. Both proximal and distal to that, it's possible to insunate the vertebral artery, but the artery is so tortuous, it's difficult to make heads or tails of it in most patients. So we have a limited view to the vertebral. Direction of flow is really important, and for novice sonographers, this can be a big confusing issue. And so here's a vertebral artery. It's hiding between these two transverse processes. You get a little peek at it in here, and here's the spectrum. Which way is the blood going? Well, it's going down. This is an inverted image, and you can tell from the color map that that's the way it's going. But you often have to think about this. People who write tests about vertebral arteries like to focus on that for some reason. Anyway, these are some things you may see in the vertebral, and the flow direction may be normal. It may be bidirectional. It may be complete flow reversal, as in this situation, and or occlusion. Usually this is a reflection of proximal subclavian artery disease, sometimes brachiocephalic disease. What about after intervention? So carotid endarterectomy, remember that operation removes the carotid bifurcation plaque. And so, a side that's treated should have no plaque. The contralateral side may very well have some. So you will see an asymmetric degree of plaque side to side. And then you'll see some findings that I've listed here. And generally, most labs will use the same criteria for recurrent stenosis after carotid endarterectomy as for primary atherosclerotic stenosis. I'll show you an exception to that. So here's a patient who had a carotid endarterectomy. This is the common carotid artery. I think you can see there's intimal stripe here, no intima here. This is the patch. Many people will do a carotid endarterectomy with a patch angioplasty. Usually you can see the patch. Many times you can see the sutures, which are pretty interesting. And again, you can see the end of the normal intima here, and then this is the patch on this side. And typically at the end of the patched segment, the artery diameter will change relatively suddenly, and that can produce some flow abnormalities and flow separation. So it's pretty common to see this sort of thing. And you may also see some increased velocities. Here's a very normal spectrum, moderately increased velocities, 206, just related to the contour of the end of the endarterectomy where the patch occurred. We're doing more carotid stenting today. Remember, carotid stenting does not remove the plaque. The plaque's still there. It's just squished up against the artery wall. Usually the stents extend into the common carotid artery and will usually cover, we generally will call that cage, the external carotid artery. And the flow velocities in the stented segment are generally elevated, and it's thought that this is due to decreased compliance of the artery wall in the treated segment, and I'll show you that. So here's a carotid stent. The common carotid artery's here. Here's the stent. The internal carotid artery goes this way, and you can see there's still plaque there that has been pushed against the artery wall. This is the external carotid artery, and again, it's caged, as I mentioned before, peak velocity markedly elevated. That's a fairly common finding that you'll see with patients with carotid stents. This is within the stented segment, and again, normal contour, really, but the peak velocity is 198, which would suggest a residual or recurrent stenosis. On the grayscale and on the color Doppler, the artery appears to be wide open. And on arteriography, you'll see the same finding. So the important point is here, if you're examining patients who've had carotid stenting, probably you need to use a different set of criteria. And there's a number of those in the literature. This is one I use. Dr. Lal is a partner of mine, so I feel I should use his criterion. But you can see that the grades for significant stenosis or serious stenosis, much higher cutoffs. Typically we'd use 125 for this grade. And he used a combination of both peak systolic velocity and a ratio. Generally, we don't like to do that, but that seems to be effective here. So in summary, I think the important thing in carotid duplex ultrasound is consistency. And that comes from having a strict or rigid or well-defined protocol for all sonographers, physician and non-physician, carefully investigating any areas of narrowing for the highest velocity. You need to have and use a well-defined diagnostic criteria. They need to be applied consistently. And the synthesis of all the images is what's important to form the impression, not just one showing a stenosis. Everything has to be put together to get the proper story. So thank you very much for your attention.
Thank you, Dr. Lilly, for your participation and for your presentation. I have a question. Do you use in your lab the flow, volume flow of the vertebral arteries in order to try to make a diagnostic of vertebral, basilar, vertebral insufficiency? Are you using this kind of?
Volumetric flow?
Yes, volumetric flow.
No. The short answer is no. Well, I'll actually talk a little bit about volumetric flow when we talk about hemodialysis a little later on. I think that it may be a useful criterion, a useful measure, but in my experience, it's difficult to be sure that you're going to be able to accurately measure flow because you have such small access to the vertebral artery to determine an accurate diameter and make sure that your cursor is filling the entire volume of the artery. I think technically it's quite difficult. And then, of course, at the base of the neck or at the top of the neck, the artery is tortuous, which is not very favorable for measuring accurate volumetric flow. So the short answer, no.
Okay, thank you.